All right. Dr. Ott, are you ready?
Oh, I forgot. Yes, I'm ready.
All right, so just a couple of reminders. The meeting is being recorded. I'll drive the agenda, but send it over to Dr. Ott to lead each agenda item. And just a reminder, we will do the roll call voting. You can aye, nay, or abstain when we get to those portions of voting. So that will take us and then public comment we will have towards the end. And I do know we have one person signed up for public comment. So with that, we will get it started. And Dr. Ott, any remarks that you have today? Call to order.
None from my end other than calling to order.
Thank you.
We have nothing to talk about.
Okay. The rest has nothing to talk about either.
I get that.
So that will take us to the third agenda item, which is approval of the minutes.
Yes, so approval of minutes. Is there a motion to approve the minutes from the July meeting? Okay, motion to approve. Is there a second?
Second.
Okay, we have a motion to approve in a second. Any discussion? Okay.
Okay. Dr. Ott.
Aye.
Ms. Phippen.
Aye.
Dr. Hart.
Aye.
Dr. Marshall.
Aye.
Dr. McCarty.
Aye.
Dr. Simon.
Aye.
Dr. Treadwell.
Aye.
And Dr. Williams.
Abstain.
Okay, so we have all ayes with one abstention, so that motion will carry. Thank you. All right, that should take us then to our meeting for our PA stats for July. Overall, we had 22,000 that were a little over 22,000 approved and a little over 5,000 denied. So we were at 81% approval and 19% denial. When we look at our point of sale quick check, we had 85% approved and 15% denied. Of the ones denied, 26% went to the call center, where 79% were approved and 21% were denied. And then on the manual PA side, we had 46% approved and 54% denied. And I think more importantly is looking at the graph here, and you might say, wow, that's a really big jump in the approvals. And guess what? Kids are back to school, much to the happiness of mothers all across the nation. They're going back to school, so we are having a significant increase in stimulant dispensing. So that is the vast majority of our increase in PA approvals is the stimulant dispensing for July and kids getting ready to go back to school. All right, so no shocker here for our top 10 for point of sale quick check. Stimulants are in the #1 position there, and you could see with almost 8,000 PA requests going through, with the vast majority of them getting approved. And then the clonidine guanfacine PA also had an increase, which again, kids going back to school, but also we did make some updates to that PA. So we had a few additional items that were going through there. And then antipsychotics, which have continued to be in the top 3. On the manual PA side, as you might remember, we switched the GLP-1s over to manual PAs. So they were in the top position along with early refills and laxatives and cathartics. The top 10 here, fairly consistent. Things occasionally shift in and out. Wegovy and Zepbound continuing to be in the top 10. So just noting that. Any questions before we move on to the opioid statistics? All right. Well, our opioid statistics actually were very consistent with where we were in June. So no real change in our total opioid utilizers, and our new utilizers decreased. And again, I think this plays in a little bit to maybe what we were hypothesizing, that over the summer we had a lot of elective procedures, especially in some of the kiddos that were in school. And now that the summer is ending, we're seeing some of that go back down. But we'll continue to watch it. In the under 18, fairly consistent. And the day supply is less than 5, which is what we would expect. You can see the numbers there as far as the utilizers and PA exempt. We are at 350 MME right now as of July 1st. And so we're still working down in that 250 to less than 500 group. But we are steadily making our way down, and our next move will be in October 1st when we go down to 325, I believe. So here's our 90 and above group. So again, most of our individuals are in the less than 90 and fairly consistent here. And then when you look at our overall trending graph, again, very consistent, except we do see that slight decrease in July compared to where we are seeing kind of that uptick or increase a little bit over the May and June time period. And then here's our less than 90 trending graph. So again, very steady with what we've been seeing over the past several months. And then actually very similarly on our 90 and above graph, very, very similar kind of look here of where people are at, very steady. Any questions on opioids? All right. Perfect. We've got a lot of material to cover today as far as MHQAC recommendations and PDL, so we'll just jump right into that. So for MHQAC recommendations for utilization edits, we have Bucapsule, which is a buspirone capsule. They were super creative with their name. They have a 7.5, a 10, and a 15 milligrams. The recommendation is for the 7.5 and the 15 at 3 per day and the 10 milligrams at 4 per day. FANUP, the titration packs B and C, updating those to 1 pack per 90 days and ages 18 years and older. And then hydroxyzine, the 10 milligram per 5 ml syrup, adding a quantity limit of 200 mils per day. And then some updates to the clonidine IR and guanfacine IR quantity limits. So the IR at the 0.1 milligrams at 12 per day, the 0.2 at 6 per day, and the 0.3 at 4 per day. And then the guanfacine 1 at 3 per day, along with the 2 at 3 per day. And then as far as the PAs, so along with the clonidine and guanfacine, there's an added max daily dose limit to both of these products that if they're exceeding their max daily dose limit, they will be reviewed on a case-by-case basis. So if they're for the clonidine IR and ER and XR, whether it's a tablet, patch, or suspension, if they're greater than or equal to 18, it would be 1.2 milligrams per day. And if they're less than 18, it's 0.4 milligrams per day. And then the guanfacine IR, ER, all ages is at 7 milligrams per day. For the sedative hypnotics and benzodiazepines PA, there was an update added to the verbiage that a lack of claims history for 90 days within the past 180 days would categorize the member as an initial utilizer versus an established utilizer. And what we're really trying to do here is what we've noticed is that individuals either paying cash or saying that they're established because they've only used 30 days or 14 days, and then saying, well, they're an established benzodiazepine user, does not really qualify as that. So we're trying to update the language to make it abundantly clear what is going to qualify for somebody who's considered an established utilizer. And then Spravato is getting her big girl PA and is going to be posted online in her own PA criteria. And she will have established quantity and age limits and approval duration. So the treatment-resistant depression is approval up to 6 months, and major depressive disorder with suicidality is approval up to 2 months. And that criteria was set to you all for review. And also here on the screen. So you can see just for the updates, there was addition of consultation with a psychiatrist and psychiatric specialist. They need to be enrolled in the REMS program and that they don't have any contraindications. And then in the reauth criteria, there was an addition of history of the requested agent for 84 of the past 112 days, and that the member has a diagnosis of treatment-resistant depression. I can tell you we have been reaching out to the manufacturer to see if there's any data on how often individuals should be using if they have the suicidality and depression. Like their treatment right now is shorter term, and then the question really is like how often can they be retreated if that issue were to arise again. They don't appear to have much data on that at this point. So it's something that we're going to continue to review and see like if additional data is released on that, then we may update on that as well. Any questions or concerns on all the mental health changes and recommendations? If not, if I could get a motion in a second, please.
This is Beth. I make a motion.
This is Dr. Williams, move to approve.
All
Oh,
right.
sorry. Second the motion.
You're fine. We have a motion and a second, so I will take the vote. Dr. Ott,
Aye. Kelly.
Ms. Pippin,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. Moving in then into our therapeutics committee recommendations. For the respiratory recommendations, the committee had no recommended changes in the classes listed here. For the beta adrenergics and corticosteroids, the therapeutics committee is recommending that AirDuo Digihaler be removed from the SUPDL because it is no longer manufactured in CMS termed, and that AirSupra maintain its current status of non-preferred and current age and quantity limits, but adding step therapy for trial and failure of both Dulera and Symbicort as reliever therapy. And again, this is based on the SMART guidelines of what should be utilized first in their stepwise approach. For the bronchodilator agents, the beta adrenergic and anticholinergic combinations, the Spiriva Respimat 1.25, maintaining its current status and quantity limit, but removing the step therapy requirement around the diagnosis of asthma. For the nasal antihistamines and nasal anti-inflammatory steroids, removing both Patenase, the brand only, and Becanase AQ from the SUPDL as they are no longer manufactured in CMS terms. For the oral inhaled glucocorticoids, removing Flovent HFA, the brand only, and the Flovent Discus brand only because they are no longer manufactured in CMS terms. For the pulmonary antihypertensives, TAD leak suspension, moving to preferred and updating its PA criteria to clarify the step therapy requirements as it's preferred. And then Eutrepia, moving to non-preferred and adding to the pulmonary antihypertensives PA with drug-specific PA criteria. It's a new agent. For the respiratory and allergy biologics, for Dupixent, maintaining its current status and updating PA criteria, it has new indications for chronic spontaneous urticaria and bullous pemphigoid. So adding both of those indications to the PA criteria with step therapy. And then updating the PA criteria for COPD indication to include the severity of COPD, which is a post-bronchodilator FEV1 of 30 to 70% predicted. And then criteria around that the member must have documented signs and symptoms of chronic bronchitis, which is often a chronic productive cough, for at least 3 months during the past year for the COPD indication. For Nucala, maintaining its current status and then updating its PA criteria to include COPD with eosinophilic phenotype indication and with criteria specific to that indication. Xolair, maintaining its current status and it has updating its chronic spontaneous urticaria indication to include the step-through adjunct therapies or advancement of histamine blockers. And this is just to be consistent with the Dupixent criteria. So we're aligning that. And then for all agents in the respiratory and allergy biologics PA, updating the reauth criteria to include that the member has demonstrated a positive clinical response to therapy. And there's several examples there of what that could look like for continuation of therapy. And that concludes the respiratory agents. Any questions or concerns there? If not, if I could get a motion in a second, please.
This is teacher. Move to approve.
Seconded.
All right, I have a motion in a second. Dr. Ott,
Aye.
Ms. Pippin,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. For the anti-infectives recommendations, the therapeutics committee has no recommended changes in the classes listed here. For the antivirals, influenza and COVID-19, amantadine and rimantadine, Removing from the SUPDL, neither of these are recommended for prophylaxis treatment of influenza A infection. And so they will be just maintained as neutral agents. And then for the rimantadine, we're removing the age limit as well. So they will be available. They're just not going to be in this class on the PDL. For the cephalosporins third generation, the Suprax chewable tablets and suspension brand only formulations are no longer available in CMS terms, so we are recommending removal from the SUPDL. For the macrolides, ZMax suspension is no longer manufactured in CMS terms, so recommending removal of that. As well as the Locrax kit for the topical antifungals, removing that as well. And then in the topical antiviral and anti-inflammatory steroid combinations, Zarice is still available, but it will not be participating in the MDRP beginning 10/1 of 25. And so we're recommending removing that as well as just removing this entire drug class from the SUPDL as there's no other agents. And that concludes the anti-infective recommendations. Any questions or concerns? Hearing none, if I could get a motion in a second, please.
This is Pat. Move to approve.
Teacher, second.
All right, I have a motion in a second. Dr. Ott,
Aye.
Ms. Pippin,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. Moving, Dr. Ott?
You're fine. Go ahead.
Okay. For the cardiovascular recommendations, the Therapeutics Committee has no recommended changes in the classes listed here. For the beta adrenergic blockers, the Coreg, IR, and CR brand only are no longer participating in the MDRP, so they need to be removed from the SUPDL. And then the low pressure solution, moving to non-preferred. This was previously neutral and step therapy that the member is unable to swallow the tablet formulation. For the beta adrenergic blockers with diuretics, the Zyac brand only is no longer manufactured in CMS terms, so removing that from the SUPDL as well. And then same thing in the calcium channel blockers with Kalin SR, the brand only, removing from the SUPDL. And that concludes the cardiovascular recommendations. Any questions, concerns? I could get a motion in a second.
Move to approve.
Teacher,
Sorry, Peter.
second.
All right, I have a motion in a second. Dr. Ott,
Aye.
Ms. Pippin,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. For the lipotropics, the Therapeutics Committee has no recommended changes in bile acid sequestrants. For the fibric acid derivatives, the Trilipix capsule, that's the brand only, is no longer manufactured in CMS terms, so removing that from the SUPDL. And then for the HMG-CoA reductase inhibitors, the atorvastatin moving to preferred and maintaining its current step therapy around age and ability to swallow. And then for the lipotropics, the Tryngolza, moving to non-preferred, it's a new product, and adding to the PCSK9 inhibitors and select lipotropics PA with drug-specific PA criteria. And that concludes the lipotropics. Any questions or concerns? If I could get a motion in a second, please.
This
Dr.
is
Marshall,
Beth.
move to approve.
This is Beth, second.
Thank you. I have a motion and a second. Dr. Ott,
Aye.
Ms. Pippin,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you. In the anti-migraine recommendations for the Nurtec, ODT, and Ubrelvy, maintaining their current respective statuses and quantity limits, but updating the initial authorization to include previous trial and failure of 2 triptan agents for the acute migraine indication. So historically, it's been 1. I would like to update that to 2 different triptan agents. And then Symbravo is a new agent with meloxicam and rizatriptan, moving that to non-preferred, adding a quantity limit of 1 bottle, which is 9 tablets for 30 days, and then step therapy that the prescriber must provide documentation that the separate components are not suitable for use. And that concludes the anti-migraine. Any questions or concerns? If not, if I could get a motion in a second.
This is Beth. I move to approve. Second.
Thank you. I have a motion in a second. Dr. Ott,
Aye.
Ms. Fippen,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCurdy,
Sorry, aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
Thank you. We have all ayes. That motion will carry. And the electrolyte depleters, there are no recommended changes. If I could get a motion in a second for that, please.
Move
I
to
know it feels
approve. This
silly.
is Pat.
Do we have a second?
I'll second.
Second, Dr. Marshall.
All right, we have a motion and a second. Dr. Ott,
Aye.
Ms. Fippen,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, motion carries. Thank you. For the MS agents, the Bapurtam was previously preferred, recommending moving to non-preferred in the non-preferred 2-step criteria that includes a step through Vumerity. And then Briumvi moved to preferred. It was previously non-preferred into the 1-step criteria. It was previously in a 2-step. Trying to, again, move some of the more highly active, efficacious agents into the preferred and either without a step or in a 1-step position. And that concludes the MS agents. Any questions or concerns on MS? If I could get a motion in a second.
This is Beth. I move to approve.
This is Kelly. I'll second.
All right, I have a motion in a second. Dr. Ott,
Aye.
Ms. Fippen,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Pass. Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. So for our biggest class, bear with me, there's a lot happening. I like to say we had like 3,500 biosimilars approved over this last month. Not really, but it is a lot. Definitely Humira and Stelara biosimilars have exploded. So there's a lot happening here. So I'll try and get us through it as painless as possible. I just about said as painful as possible. It might be that. I'm sorry if it is. So for the adalimumab ADAZ, the unbranded Hiramaz, that is going to be moved to preferred and in the preferred criteria, as well as Hadlima. Those are going to be our 2 new preferred agents for Humira. Spoiler alert, Humira is moving to non-preferred. We'll get to that. But I just want to point that out now that those will be the 2 preferred agents because there's a lot other agents that we're going to go through. So in the adalimumab FKJP, the unbranded Julio, that is going to move to non-preferred and the two-step position criteria. Ebglyss is going to be maintained as non-preferred and move to the non-preferred one-step PA criteria. And then updating the PA criteria to remove the trial and failure of at least 2 other targeted immunomodulator agents and just maintain a trial and failure of Adbry, since it's going to have a one-step and the one-step should be through Adbry. For Humira, as I previously mentioned, it is now going to move to non-preferred and into the non-preferred two-step criteria. I should also mention for all of these biosimilars, you will have your preferred agents and then you'll have the non-preferred in a two-step position. And really that criteria is looking around rationale as to why you can't use the preferred biosimilar agents. And just as kind of another note or point, all of the biosimilar agents that we place as preferred, we do make sure are interchangeable. We do make sure that they have all of the same indications. So really, the only reason somebody shouldn't be able to use those agents is if they have issues with the non-active ingredients or allergies to that or something along those lines. So that's really what we're looking for in the criteria. We also have validated before we move this that there is enough of this product available. As I said to the T committee, Hadlima can Hadlima the world. They have enough to cover the entire nation's need for adalimumab. So we did validate that as well before we move these agents. So getting into some of the Stelara biosimilars, Imodulsa is moving to non-preferred into the two-step preferred criteria, or in the two-step criteria, non-preferred criteria. I just went the wrong way. Okay. Lexelvi is moving to non-preferred. This is a new drug adding to the non-preferred two-step criteria and drug-specific PA criteria associated with it. Nemluvio moving to non-preferred in the one-step position and maintaining its existing PA criteria. Pyzchiva will be our preferred one-step criteria and our preferred agent for Stelara, along with Solarisd, which is on the other side of the screen. It will also be in a preferred one-step position. So Pyzchiva and Solarisd are the two preferred biosimilars for Stelara. Rinvoq, maintaining its current status and updating its PA criteria to include its new indication of giant cell arteriitis with indication-specific criteria. Simlandi moving to non-preferred into the two-step criteria, and then Tremfya maintaining its status but adding a moderate to severe Crohn's disease indication with indication-specific PA criteria. Tyenne maintaining its current status and adding its new indication of cytokine release syndrome with drug-specific criteria, and then Usemri moving to non-preferred into the two-step criteria, another Humira biosimilar. I've already mentioned this, but for the non-preferred two-step ustekinumab, this is the Stelara biosimilars. They will maintain their current status, but they will now have to have previous trial of all the preferred ustekinumab products, which, as I mentioned, was Pyzchiva and Solarisd, or they have rationale as to why they cannot utilize. Another thing to note is that the adalimumab recommendations are going to go in 10-1 instead of 11-1, just due to some contracting. So we've had some notice that's already been put out on that. So I just want to make sure that you guys are all aware of that. So to recap this class, several new indications added to several products. Hadlima and the adalimumab, which one is it? The Hiramaz. Yeah, the unbranded Hiramaz are going to be our two adalimumab biosimilars, and then Pyzchiva and Solarisd will be the two Stelara biosimilars that will be preferred over their other agents. Any questions on any of those? That was a lot. If not, if I could get a motion in a second for those, please.
This is Kelly. I move to approve.
This is Beth. I second.
By the looks on everybody's faces, I made that painful instead of painless, so my apologies. I have a
Aye.
motion and a second. Dr. Ott,
Aye.
Ms. Pippin,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry, and thank you. We made it through the T committee recommendations. You have survived. We now go to the managed care updates. Any managed care updates today? Amy's trying to avert my gaze. So she clearly has no updates she wants to recommend. Anybody on the phone have anything they need? All right, hearing none, we will then move on to our new drug recommendations. So in the non-SUPDL agents, the PA and step therapy, the Ciclose, which is a hydroxyurea tablet, initial authorization will be that the member is unable to swallow the capsule formulation, or that the prescriber, or that the prescriber has submitted medical justification for use of Ciclose over the hydroxyurea capsules. I would argue if anybody says a tablet is easier to swallow than a capsule, I find that hard to believe. Oh, they're dissolvable tablets. I lie. Okay, so I guess maybe that's easier, but still the capsules are pretty easy. So hopefully that will be okay. On the reauth, the member has a history of the requested agent within the past 90 days, and they continue to be unable to swallow the capsule formulation, or that the prescriber has submitted the medical justification we just discussed. And then Xromi, which is a hydroxyurea solution, very similar to what we just saw on the other pages, that the member is unable to swallow the capsule formulation, or they have submitted medical justification for use of this. And then same thing on the reauth criteria, that they have history and that they continue to be unable to swallow the capsule formulation. And that concludes all of our new drugs. Any questions on either of those products? If not, if I could get a motion in a second, please.
Move to approve. This is Pat.
Second. This-
Okay, I have a motion and a second. Dr. Ott,
Aye.
Ms. Pippin,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCurdy,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes. That motion will carry. Thank you. Any liaison with other boards? We should make note, Dr. Ott attended her first therapeutics committee meeting, so that was exciting. So now she liaises for all the boards and committees.
I was going to say, was it?
It was for me. I don't know
Oh,
about for you.
woohoo. So yes, apparently I do liaise for all the other committees.
Along with Dr.
Well, so does
Marshall.
Dr. Marshall though, so we can't leave him out.
Yes, he can also.
No,
liaise.
you're the rock star. You're the
No,
rock star.
All right, hearing no comments there. Any old business? I'm also hearing no old business. Anybody have new business before I get into the one that's probably, hopefully not going to blow everybody's mind? I'm really hoping I can make this one be the painless one. All right. Grab onto your hats, folks. We're going to talk GLPs again. And we're going to talk about Zepbound. We came back, hopefully with good news, Dr. Marshall. So in the initial criteria, after our discussion at the last meeting, we were able to discuss with the manufacturer and get criteria approved that allows for either they've had a sleep study in the past year, and we've discussed all the criteria associated with the sleep study. I'm not going to get into detail on that unless you need to. or they have continued to use their CPAP BiPAP, and they've had a sleep study at some point. We know that if they have a CPAP BiPAP, they had to have a sleep study, right? Nobody's going out and buying one. And that they have documented adherence within the past 90 days, and that adherence is the greater than 4 hours of use per night for greater than 70% of nights, which ends up being like 20 days. This can be supported through either chart documentation or through their actual sleep report, should they have that, but they don't have to submit that. They can submit chart documentation. So that if somebody is regularly using their CPAP or BiPAP, they shouldn't have to have a sleep study done within that past year, and we're not going to penalize them for using that. We did get agreement to have that added into the criteria. For the reauthorization criteria, we did remove the requirement of having to continue to use the CPAP or BiPAP because they may or may not use that, or individuals may not be able to utilize that. But we are still going to be looking for meaningful weight loss from baseline. And on the initial authorization, like the first reauthorization, we would be looking to see that they are decreasing their AHI from baseline. Does that help alleviate any concerns we had from the previous meeting, Dr. Marshall?
I'm really confused now. I understand the initial authorization, and you said you've taken out the year, right?
Well, the year is still there if they're not on it. So if they're not consistently using a CPAP or BiPAP, then they have to have a sleep study done in the past year, demonstrating the moderate sleep apnea, right? So it's one or the other.
Why?
Because that's what's.
Because that's the indication,
Yeah.
is having sleep apnea. So either
Right,
they've had
but if they've had one 3 years ago and it shows that they have sleep apnea greater than, that's moderate, and they're not using the CPAP consistently, why are we doing it again?
because maybe something changed within, now I know, because I know what you're
No,
gonna say. You're
no,
gonna say,
no.
Amanda, nobody loses weight in those 2
Right.
years, and that it's
Right.
not going to happen. But I would argue, what if somebody had a tonsillectomy and now all of a sudden they don't have sleep apnea? I mean, I know
Yeah.
that this is gonna be rare,
All right,
but the idea is,
tonsillectomies are not, in adults, are not going to get rid of sleep apnea. That's not that's in kids, but that's not in adults. That's not a
I don't want to
treatment
hear this
deal.
version. My
The UP
18-year-old daughter just had this done for sleep apnea. She had her tonsils
Well,
removed.
Well, that's in kids. That's in kids, I'm saying. But that, which I'm talking over 18, but it's usually a UPP, I think a UPPP, and they're really not doing those anymore. That's not really been shown. You have to have certain guidelines to even to say that's going to work. I'm not sure why we're repeating it. I know you have to repeat it in Medicare and most insurances. If you're not using the CPAP, you have to do it again to get back on the CPAP. But if they have
Exactly.
the CPAP, I don't know why we're doing it, but okay, all right.
Well,
Now,
if they have the CPAP, they don't have to have a sleep study in the past year. So like if they're using a CPAP,
right.
they can have a sleep study done 15 years ago, and I don't care, as long as they're using the CPAP too and they have that sleep study. But if
Yeah,
they're
but
not,
if they're
using
not,
CPAP,
if they're not you documenting that they're using it, then you're forcing them to do another sleep study. I just don't get it, but okay. Now I'm a little on the reauthorization. Explain to me how this works again.
okay, so for reauthorization,
And when is that? 6 months, a year?
6 months, right? The first 1 year for the first reauth. Okay,
Okay.
sorry. So 1 year, if
Right.
they've been using the agent consistently, so they need to have 84 days within the past 112 days. So we give them some leeway.
Okay.
So that's the first criteria point. The next criteria point is that on initial reauthorization only. So this means they've been on therapy for at least a year or more, but they have been on therapy for less than 2 years. So it's their first request to get a new PA.
Okay.
then at that point, we're going to ask them that they have shown that there's a demonstrated reduction in AHI from baseline. That can be from a sleep study that they've had, in addition to that they've demonstrated meaningful weight loss from baseline, which is at least 5% is what we have in here.
I don't see that. Oh, you're adding that on so that you're keeping the 5%.
Yeah, keeping the 5%. Yeah, sorry, this just
Okay.
has what the changes are. So the 5% weight loss is still going to be there. And we're still going to have that they don't have, central or mixed sleep apnea, et cetera, and the
Okay,
dosing is still
okay.
there. So this is
Now-
just, we're updating the removal of, and then we removed the requirement around having to continue to use the CPAP in the reauthorization space. So they
Right, now,
don't
do you-
have to keep using their CPAP in the reauth.
Now, it says here that you're demonstrating the reduction in the AHI from another sleep study. Is that right?
So we're looking to see if the drug is effective for the reason it's indicated. Sleep apnea.
Okay, but you're asking a reduction in the AHI, right? Is that what you're saying?
Correct.
Okay. Now, do you know that when you use CPAP, your AHI goes down?
Correct.
Okay. We don't usually do another sleep study if they're using the CPAP, because you can document the reduction in the AHI from the use of the CPAP. It demonstrates how many events you're having. Most machines will say how many you're having. So this is a little confusing. I mean, if they're losing weight and you're making them do another sleep study,
So-
I
It's actually, to clarify, this is not saying that they have to have another sleep study. They just have to demonstrate a reduction in AHI.
It says sleep study.
So
does.
can you add in that where it says PSG or HSAT that they or by documentation from CPAP machine? Does that fix it, Dr. Marshall?
Well, I would just say, I wouldn't be doing another sleep study. I would just be saying documentation of use of CPAP. Or I guess if they don't use CPAP, okay, I guess I would say if using CPAP, documentation that AHI is reduced, but, or if they're not using CPAP, I guess they'll have to do another study. But if they don't make the weight loss, are then you going to say you're not going to do the study?
Okay, so what if we updated this criteria point to just say member demonstrates reduction in AHI from baseline study and then cross out everything else after it and then just say obtained within the past 3 months. So wherever you've obtained that AHI from, whether it's from your CPAP machine or from a sleep study, we'll take it as a reduction.
Okay, so that you're saying they have to at least lose 5% and they have to show a reduction in AHI.
Correct.
Okay, so I guess I would just educate you then, if they're using the CPAP, that can be pulled off from documentation. If they're not using the CPAP, I guess you're gonna have to require then another sleep study.
Correct.
Okay, so that's how I would do it. That and I would be good with that, but I wouldn't require a sleep study on somebody who's using their CPAP, because if you use your CPAP, your AHI should be less than 5. Or they're having to make adjustments. The bigger question is, most people don't want to use the CPAP. They're going to try to use this drug to get off the CPAP is what they're going to do. And I'm good with that they have to show documentation in 5% then. I'm good with that. Okay.
So if you remove the what's in parentheses there, do you think you're going to get just, I mean, is it going to be, are providers going to understand that there has to be a documentation in the note of either a sleep study or reading of a CPAP to be able to get the PA? The reauthorization?
I mean, I
Probably
think we can,
not.
what we can put in there is we'll say member demonstrates documented reduction in AHI from baseline study, and then in parentheses, we'll say like chart notes or whatever, and so then they can.
Well, I would say, use of CPAP or documentation of a recent sleep study.
So we could say in the parentheses, we could say sleep study report or CPAP report.
Well, I would say, you're gonna have to say a new CPAP report. I mean, a new sleep study. You can't use the old one. They're gonna
It says
submit the old
obtained.
one.
It says obtained within the past 3 months. Like, we'll keep this statement here in.
So by definition, doesn't the word demonstrate means to show? And to show, you have to show with something. So I'm trying to not add too much in here to put parameters around things. This, when you talk about the word demonstrate and it's just showing something that demonstrates it, if we start to talk about chart notes, blah, 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 it kind of, now you've narrowed the definition where somehow it's been demonstrated.
No,
By
you're
whatever
gonna have to explain it what you need, I think, because you got to realize in many parts of the state, there are not sleep doctors taking care of these people. It's primary care doctors that are not really trained in sleep apnea. Okay.
Yeah.
And unless you really document what they need to do, they're not going to understand. And I'll be honest with you, there's a lot of people here in the city that I've sent them to sleep doctors, and they quit going. They get on the CPAP, they use the CPAP, they feel fine, they quit going, or the sleep doctor doesn't follow them back up. It's interesting. It really is interesting. And then it falls, then they come to me wanting their supplies, which I tell them I don't do that. But in the rest of the state, there are not a lot of sleep doctors, and primary care doctors are doing it, and they're not trained in it. And so you're going to have to really say what you need here.
Okay.
So we'll update something around that then. So does that make sense though, as far as the criteria? So the update will be, we'll cross out the requirement for a new sleep study, but it'll be documented that either in a new sleep study or documentation from their CPAP BiPAP machine.
Correct. I would go with that. That way you cover the 50% of people that don't use the CPAP.
Anybody
But
else
they've
have
got-
any? Sorry.
Got to show weight loss too. They got to show weight loss too. And if they're
Correct.
not taking it regularly, then they're not going to show weight loss.
Correct.
Yeah, I could go with that.
Well, we're gonna actually like add in the CPAP, yeah. We'll put like EG example, this CPAP, BiPAP, yeah.
Yeah, CPAP/BiPAP. Yeah.
We were just discussing what it was gonna look like on the PA with our managed care partners across the table here,
Okay.
so we were
Yeah.
all clear.
Yeah.
Anybody else have any other questions or comments on what we're updating for this before we go on to a couple other items in the new business, and then we'll take a vote on everything? All right, thank you for your help with that. I know that was a lot, but we'll probably update it again next month, I'm sure. I feel like we never can get away from it. So some vaccine edits. This is informational only, but the ICSCHIC, we just want to keep updating it every other month. And so there was a CDC recommendation to pause use above 59 years of age. That was then removed. I don't know if you've noticed, but the chikungunya virus is going around everywhere and people are dying. So they've decided that we really probably should put this vaccine out and available to people over 60. So we are maintaining our previous edit of no max age. So this is just an FYI that we wanted to let you all know. And then this is also an FYI, and there are several things happening here. We did have a major manufacturer that is removing themselves from the MDRP as of 10/1. They have a lot of products. We're not going to be able to reimburse for them. I don't think we've heard that they plan on rejoining at this point. So the products are listed here. There are, in most cases, other options, and a lot of these are brand products where generics are available. But we just wanted to make sure you all were aware of this. Some of these products were on our brand preferred list, so we had to make updates around that as well. So I'm not going to read through all of them. There are a lot. Yeah, 3 pages worth. There are a lot. So just want to point that out. Probably, I feel like potentially one of the bigger ones that doesn't really have any other alternatives. I mean, aside from Zarice, which nobody uses, so I don't know that that's really a big deal, is Saliq is on there. You might notice there are not other generics alternatives to that. That doesn't mean there are other alternatives that cover the indications. It's just that that's probably the one that stands out the most. All right, so really we're only taking a vote on, this is informational only as well. These are some of the products that we had to remove. So you can see those products there that are getting removed based on the changes that were just made. And then we do have a couple of additions that are going to go in on 11/1, Arnuity, Ellipta, Difficid, and Vuity. And then removals on 11/1, Cellzentry. Any questions on any and all of that? And so really all we're voting on is the updates to the Zepbound criteria.
It's Dr. Marshall, move to approve.
Second.
This is Petra, second.
Got a couple seconds, so I'm good. I have a motion and a second. So Dr. Ott,
Aye.
Ms. Pippin,
Aye.
Dr. Hart,
Aye.
Dr. Marshall,
Aye.
Dr. McCarty,
Aye.
Dr. Simon,
Aye.
Dr. Treadwell,
Aye.
and Dr. Williams.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. We will get ready for our public comment.
Wait a minute, I want to ask a question about new business.
Please go right ahead.
All right, have you guys, with the issues with the Sarapa muscular dystrophy drug, have you made any changes into those guidelines or decisions?
Are you talking about the 11?
Elevidus from
Yes.
Sarepta.
Yeah, we added a notation onto the prior authorization criteria posted online to their news release for the, I think, the FDA communication.
So you made what addition? I couldn't hear you. I'm sorry.
Sorry, we added a notation onto the public facing criteria that's posted on our website, linking to the FDA news communication.
Mm-hmm. And what is that? Don't use it in non-ambulatory?
Well, I think they actually reversed that. So it's still able to be used in non-ambulatory currently.
Oh, they did. Okay.
Yeah.
Okay. So they didn't make any changes on the use then?
No, they were going to, and then they
reversed it.
So they kind of
Oh,
went.
okay. Well, my bad then. I thought that was recommended not to use it in non-ambulatory. Okay.
Yeah,
It did for a short period of time, and then they kind of like X-Chicks, they just back and forth.
Okay. Well, thanks for that update then. Thank you.
Any other new business from the board? All right. That's not what I wanted to go to. I want to go to public comments. I believe I saw Dr. Hamoud on the phone. thought.
Yeah, I'm here. Can you hear me?
Yes, we can. We
Yeah,
will let
great.
you take it away.
Thank you. Well, thank you for this opportunity. My name is Jalal Hamoud. I'm the MSL here at Medunique. I'm presenting Cyclos as treatment option for sickle cell anemia patient. Cyclos is the first FDA-approved hydroxyurea indicated for patients 2 years of age and older with sickle cell anemia. Hydroxyurea remained the gold standard disease-modifying treatment for sickle cell anemia because of its safety and efficacy shown in several clinical trials. However, during those trials, the dose was always precisely adjusted to the patient's body weight, which is not the case in real practice. The film-coated Cyclos oral tablets are available as 100 milligrams scored tablets, 1,000 milligram triple scored tablets, which offers a variety of strength from 50 milligram to 1,000 milligram to help the physicians to titrate correctly and precisely each patient based on his weight. For patients who are not able to swallow the tablets, these can be dissolved in a small quantity of water on teaspoon. In prospective and observational clinical study in almost 2,000 pediatric patients and adult patients treated with Cyclos for 1 year, there was a highly significant decrease in painful crisis, in acute chest syndromes, in hospitalization, and in blood transfusions. The NEH guidelines recommend starting hydroxyurea at 9 months of age. In fact, Cyclos has been studied in pediatric patients less than 2 years of age with published data demonstrating its efficacy and safety compared to placebo in this patient's population. A label change request is submitted to the FDA to include patients under 2 years of age. However, please note that the indication is currently limited to patients 2 years of age and older. For important information, safety information on Cyclos, I refer you to the Cyclos prescribing information. Thank you, and I respectfully request that Cyclos be added as preferred drug list, and happy to answer any question. Thank you.
Any questions for Dr. Hamoud? All right. Thank you very much. I believe that takes us to the last item on our agenda, which is adjournment. Dr. Ott, I will let you, oh, hold
on, sorry. We just told me I'm wrong on the Elevidus, that it really isn't allowed in non-ambulatory.
Yeah,
Sorry.
but they do 2 checks on it before the manufacturer ships it. So that's why we decided not to incorporate into the criteria, because
They do their own checking.
they do.
Okay, could you all hear that? We had 2
No.
soft speakers speaking.
No.
Okay, so so it really is not recommended to be used in non-ambulatory, the Elevidus, but
Right.
we have not added it to the criteria because the manufacturer is doing 2 separate checks to validate that before they ship the drug. So they're doing their checking before they even ship the
Okay.
drug out for the patient.
Okay, that's what I thought, that non-ambulatory was not to be used. That's where the
Sorry.
deaths have been. Yeah, okay.
Our bad. I thought
No
for sure
problem.
they were, but
I'm probably getting confused with the XG.
It's on their website that it's for both.
It is still.
Yeah, but we'll just go.
You thought it was reversed too?
I thought it was reversed too. That's what I thought I got, but we'll come back with more if they've done something different, we'll let you know. But at least right now, that's what it looks like. So we'll
Sounds
continue
good.
to follow.
Mhm.
Thank you. Anything else from anybody else before we adjourn?
Is it my turn yet?
It's your turn now.
Okay, so we will
Oh.
adjourn this, huh?
Oh, sorry. I'm interrupting you again, but it's because of Mr. Ross. It's not my fault.
Sorry. So are we, going to get, I'm sorry, guys. You guys know more than I do.
We were just going to bring up the meeting schedule for next year was sent
Oh.
out, and there were some changes to that in which it's no longer monthly. It's what would it be?
8 months a year.
8 months out of the year. So
So the new agenda for next year, the new calendar, if you have not looked at that, please do, and please get back to us. We're having to make some changes around when we hold meetings due to some contracting and new 60-day notice. So the DUR board will now meet 8 months out of the year versus 12. So huzzah, you have a little bit of a break. And if you cannot make some of those meetings, please let us know. sooner rather than later, so we know if we have any quorum issues.
Have you sent those dates out?
You didn't get,
We did, but we can resend it again today, just
Because I
so it's
didn't
up.
see that. I didn't see that. Thank you.
Sorry, Dr. Roth. Didn't interrupt your adjournment.
I'm glad you brought it. I didn't know that was.
All right. Who else wants to interrupt Dr. Ott after she starts speaking? I'm looking at just the general audience, so.
Okay, I'm just
All right.
waiting to make sure that I'm good to go.
I think you're officially good.
Woohoo! Okay, we will adjourn this August meeting of the DUR board. Happy Friday, everyone, and have a good weekend.
Thanks,
Thanks.
everybody. Appreciate it. Have a great weekend.
thank you. Thank you.
Oh, wait, what's wrong with it?